The opportunity here, and that's why I wrote the book, is if we can pick up brain inflammation and what may be underlying and contributing to the brain inflammation that is contributing to these psychological symptoms, then we have the ability to change the trajectory of a kid's life.
Welcome to the podcast. How you doing?
Yeah, I'm doing great. It's great to be with you, Jess.
We're going to have a great conversation. I'm looking forward to it. And I'm curious, you've been in practice now for 38 years. That's a long time.
Wow.
23 of those years you've been focused on kids. Let's talk about the pivot or when you honed in on kids within that point in your career. What was the catalyst to make that shift?
So it's a really interesting question, actually, Jess. Uh, what happened is in 1997, I wrote my first book called The Road to Immunity. And it was all about how to survive and thrive in a toxic world. It was all about the immune system. And around that time, I started doing some clinical research on something called transfer factors, which are these small little peptides that help cellular immunity. And I wrote a little bit about Th1, Th2 imbalance. This is 97. You're talking about going back, 24 years now. But it's still quite relevant, actually, although there's obviously been a lot of progress in the immune system. And I found, I learned about factors. I was doing some research as to where they would be appropriate, what type of autoimmune diseases, what type of chronic infections. And someone from the autism community, and at that point, a couple of years ago, they had started something called Defeat Autism Now, which is an organization looking to try to unravel the puzzle and get to some of the answers to help kids with autism because the incidence was really rising rapidly. And so I got asked to give a lecture. I remember it was May. I remember very clearly. It was May 1998. They didn't know me from a hole in the wall. I was put at the end of the day, 5 to 5:30. I figured, everybody will be gone. They'll be off to the bar getting a drink, or some will go home or the hotel room. There's a lot of people in the audience still. There was a lot of people at that conference, and I gave this lecture. And I generally can give a really good scientific lecture. And the organizers of the conference were like, "What is he going to say? This or that?" But it turns out that everybody was quite impressed, and I became very intimately involved with the organization. Lectured for years and years. But what happened is the families and the parents in the audience, as well as it wasn't a lot of doctors in those days who were doing that kind of work, and psychologists, but they heard about what I was saying and my integrative medicine approach, which most people didn't have. You're talking about 1997. So the family started to bring the autistic kids, eventually from all over the country. And then as I started to get results, they came from far and wide around the country. And the word got around very quickly in the autism community, and even went abroad. So people started coming from many other countries to see me. So I ended up with thousands of autistic kids. So they essentially overran my practice, quite frankly. And it's not that I never saw other things or any adults, but they became a huge part of my practice, and I got really good at it. I helped thousands of kids, and that's really it's. And then I always say, like 20 years later, I look back and I wrote a book 20 years after that on the 4A's. Healing the New Childhood Epidemics: Autism, ADHD, Allergies, and Asthma. And I always said, if somebody would have asked me, at that point in 1998, if in 20 years you would have the expertise you had with autism and have thousands of kids, I would have said, you're crazy. And so you never know. I tell this to my kids, you never know where your career will go. And I ran with it because, number one, it was very gratifying to help heal the kids, and in doing so, healing the families. And so it was really interesting. I love the complexity of problems that it really have to solve, and there's a lot of solving problems in that population. And but then again, so just so to take the next step, that was the segue into the families coming from all over, bringing me kids on the autism spectrum. Then they would say, "Do you mind taking a look at my other child? He or she's not in the spectrum, but he's got or she's got anxiety or OCD or some mood dysregulation, rapid cycling mood swings, what have you, panic attacks." And and not only the kids, but the family members as well. So I started seeing more and more kids, neurotypical kids, with mood disorders. And that over the next decade, they got increasingly large part of my practice, and I got very, very interested in what was causing that. Very, very similar in some ways, brain inflammation, and obviously that led me to my latest book, Brain Inflamed. But it was all of that, each one segue into the next. It's a little long-winded, but I think it's really important. That's really, I mean, I have to be honest. Way back in the '90s, I would never have imagined I would have had thousands of kids with these kind of disorders. But that's what's happened. It's been a terrific, terrific avenue for me in terms of what I've been able to do, what I've learned, and and the people I've been able to help. So I'm very happy for it. But it was not something I had planned.
So going all the way back to that lecture at the autism conference that you did, before that, what was your experience working with kids with autism?
I had a few. I didn't have many. My first one was probably, I think, 1995. I can remember because he's still in the practice. He's an older kid now, severely affected. He came to me with severe food allergies. I remember that very well. And I was able to help him with his food allergies. And I was able to offer some help with his autism, but I didn't know as much about it then. And so after that, maybe a few, but not, before that conference, not a lot. That's what I'm saying. It was not a large part of my practice in any way. And even the kids that I had usually came to me with other things relating to the immune system and like allergies or asthma or that kind of thing.
Let's talk more about the food allergies. This is an interesting thing to delve into. Talk about how often you'd see people with these back in the day. You talked about this patient back when you gave that lecture that you were already working with autism. And then how common are they these days? How has that changed over the years?
Well, I think they're more common. There's actually food allergies, which is a classical IgE food allergy reaction, kind of more like the immediate you eat strawberries and get hives, so to speak. Um, and then there's more delayed reactions, food sensitivities, which are different. They're not as severe usually. They can be very, very disguised because it can happen later. It doesn't happen right away. Um, but and so I think the incidence of food allergies has increased because the immune systems of our kids have gotten skewed, and I'm happy to talk a little bit about that in a second because I think it's contributed. But so there's more and more issues, GI issues, especially in the autism population, but certainly in all these kids with mood disorders. Anybody with a chronic illness, whether it be physical or neuropsychiatric or what have you have to look at the gut. And that, when there are problems in the gut, that can contribute in the microbiome, the good bacteria in the gut, that could contribute to immune imbalances, skewed immune systems, and more food allergies, and also food sensitivities, where if you have a permeable gut lining, where you lose the integrity of the gut lining to keep certain things out, especially larger molecules, they get in. These tight junctions get opened up. These larger molecules get in. The immune system, 70 to 75%, which lies right under this one layer of epithelium in the gut, allows these molecules to get in. The immune system sees them and they react inappropriately with an immune reaction to something that they shouldn't be reacting to, i.e., a food. And so, whether you get a food allergy reaction or a sensitivity reaction, and I do believe that there's no question it's been happening more and more. We see it more and more. I think that disruption of the microbiome, and the microbiome is that collection of the microorganisms in the gut, trillions of these bacteria and other organisms that hopefully are in a healthy diversity, a healthy balance, but frequently, unfortunately, not. And that also contributes to increasing food allergies. And I'm happy to delve into some of the reasons why I think that's taking place, but that's what I see as contributing. One of the things for sure.
Sounds good. Take that and run. Let's get into it.
Well, one of the things I think is very important is, so I think it's very interesting. In my field, we've been very much into the microbiome for years, ever since I really got into practice. I'm talking about 83. We were always thinking, we thought about probiotics and we thought about microbial balance. Obviously, in the last 5 years, I don't even think it's been 10, but the microbiome is soaring in interest, soaring in research, soaring in the clinical applications of what we call dysbiosis, or abnormal intestinal flora, and the importance of a healthy bacterial flora. So it's I'm sure most of your listeners have heard about that. Just to be clear in definitions, we use the word microbiome, but the microbiome really refers to the genetics of the microbes. It's the microbiota that make up all the microorganisms in the gut, but we interchange them, just so I know. So most people hear about the microbiome, and that's what it refers to. But a healthy microbiome is crucial. And one of the things that I think sets us up for problems, our kids up for problems early on, is all the C-sections. I mean, C-sections in this country have increased 30 to 40, between 30 and 40%. Other countries, they may be 16%. So we have a lot of C-sections. And for many years, it was probably thought, oh, they're fine. What a great thing. The baby comes out looking great, and stuff. But now we know that the baby, the infant, the neonate is deprived of that incredible journey through the birth canal and acquiring the mother's microbiota, her microbial flora, which hopefully is good. Hopefully it's not imbalanced. Hopefully it's healthy. And I'm very big on having pregnant women take probiotics so they can have a healthy microflora as well. But so right off the bat, what is the first microbes that this neonate delivered by a C-section gets exposed to? Those microbes in the operating room, on the skin, perhaps, of the people delivering him or her. And that's not good. And that sets them up for problems years later. And so I'm very big on giving C-section babies probiotics right from early on. In fact, it's very interesting what's starting to take hold now. One of my colleagues once called it a perineal picnic. You take the baby, you put him down below, and let the baby have a picnic on some of that fluid and secretions and get that bacteria. Sometimes in the OR, I hear they're taking a swab of the mother's vagina and their secretions and things, and putting it in the infant's mouth. So there is more of a recognition, and there's no question. There's research showing that predisposes a child to more allergies and other issues, because you need that healthy bacteria right from the start to educate the immune system. It's like, in essence, the kid's immune system goes to school right after birth. And the problem is we're not educating the infant well in terms of the immune system. We're delivering them by C-section like 30, 40% of the time, which is very high. We're giving them antibiotics if the mother has group B strep or whatever, or they have a little issue, and so they're put in the ICU and get 3 days of IV antibiotics. And you do that right away, and that you're also changing the microflora. And a very early change in the microflora can have ramification years later. So I think it's very important to do all these interventions very early on.
You mentioned a couple of the interventions there, specifics people could do if they, had to have a C-section. Do you know if there's any research to show that people that have done this, that the microbiome of the children is comparable to somebody who's been born, classically through the birth canal?
I can't cite a study, but I do know that there are papers I've written that, with charts and everything showing that happens. And not only the probiotics, etc., but breastfeeding. Breastfeeding supplies the prebiotics, the oligogalactoside, that there's these prebiotics in breast milk that actually, galacto-oligosaccharides, that actually is helpful too. So it's not only a vaginal birth, but it's also breastfeeding. So these are other ways that we kind of had a sense that breastfeeding obviously was helpful and was more natural. but it also affects the microbiome. So there are studies that talk about this. Everything I'm saying is definitely I've read in studies. I'm not just picking up, but I can't give percentage or anything. But I think there's more and more a realization and recognition, and we can explain. We always kind of knew breastfeeding was probably better, but we get more and more explanations as to why it's better, and this is one of them. Even its effect on the microbiome.
Interesting stuff. Let's come back to food allergies and food sensitivities. When somebody comes to you in practice, what kind of symptoms are they displaying when you think this could be an issue? And then what types of testing can you do to confirm that?
Well, I mean, in terms of a dysbiosis, in terms of abnormalities in the microbiome, or in terms of what? I'm not sure your question
Just
exactly.
specifically that they're reacting to certain foods that they're taking in through their diet.
I got you. That's the thing, Jesse. That it can be across the board, so varied. So the classic reactions are always sort of in terms of allergy reactions, whether it's inhalants like dust or pollens or foods. Foods people would think of hives or eczema, perhaps nasal congestion, asthma. Um, that's that's classic. But the other not so classic reactions can be headaches, fatigue, brain fog, GI upset in terms of either bloating or constipation, diarrhea, abdominal discomfort, um, joint aches, muscle aches, kind of those kind of generalized non-specific symptoms that people usually write off, get a couple of basic labs and say, oh, whatever, it's just this or that. But, also ADHD. I've seen kids with ADHD, meaning attention deficit hyperactivity disorder, with either lack of attention or is hyperactive, can't fidgety, can't sit still. You figure out what they're allergic or sensitive to, and you take it away. It can be dramatic. I mean, I have one example in the book of a kid who's allergic to corn, and we picked it up in the office with a skin test for corn. They reacted, took this child off corn, and corn is worse than dairy, is worse than wheat because it's in everything. Any processed food has corn in various different ways. So corn's very hard to get away from. Even supplements, the capsules of the supplements have corn in them. So, but if you're very strict and you look at it, you can have profound things. Same thing with wheat and gluten. I mean, gluten is a very common sensitivity, and it's not only celiac, which is an immunological reaction to gluten. It's also a sensitivity. It's called a non-celiac gluten sensitivity, um, where you can get not only GI symptoms, which is the classic stuff you think about, but there's a non-GI, it's called extraintestinal symptoms, where it's just neurologic. It could be unsteadiness when you walk, it could be brain fog, it could be a cognitive dysfunction. It really can vary, and I've seen food allergies cause numbness and tingling, aches and pains. Every system can be affected. I've seen it cause tachycardia, rapid heartbeat. That's the crazy thing. And that's why sometimes it's easy for a conventional doctor to say, oh, come on, nothing can do all those things. It's really in the mind. But no, you figure what it is. You get kids, we're talking about kids now, but even adults, you get them off the foods they're sensitive. You can't believe. I mean, I have autistic kids. I take off gluten and dairy, which is one of the common things we do. Kids never spoken, kids totally withdrawn, spaced out, um, and they may go through withdrawal, so they may get a little worse the first day or two because it's actually almost an addiction. And then all of a sudden they come out of it. It's like the parents will say, God, the glaze is gone. One kid said, Mommy, first time. One kid said, uh, in the yard, said, I comes back a few years later, I love you. And it's like, parent calls me crying. I mean, it's unbelievable. So that it can be very powerful. And I think in medicine, we rely so much on medications and surgery, and we forget that foods can be very powerful. They really can.
Are there certain trigger foods that are so common that people are reacting to? You mentioned gluten and dairy there. Is there a certain list that when you're working with somebody, a kid that's having mental health challenges, that right off the bat you just remove out of the diet? Or do you always go to testing first to determine that?
No, I think you can go to, first of all, you get a dietary history. So oddly enough, if someone says, I tell you, Doc, I love my potatoes. You can take anything away, just don't take my potatoes away. Guess what I'm taking away? Because a lot of times you crave what you're allergic to. These kids, a lot of the kids I see with ADHD, autism, and some of the mood disorders, what do they crave? They crave gluten and dairy. They crave mac and cheese, grilled cheese, pasta, pizza. And that's a clue. What you crave is frequently what you may be sensitive to. And it's very hard to get them off of it. This is the implementation is the challenge. Um, so I'll know it clinically. Sometimes I'll do it clinically. I will test foods. I usually test some basic foods, and if there's some positivities, we may look at more. But having the parent become aware of it, then they're looking. Hey, is there a relationship between what my child ate and how they're doing? And also, there's something that for every kid I take off is the food additives, colorings, flavorings, and preservatives. And that's been well documented. There was a study in 2008 from Wales in the Lancet, one of the most respected, like our New England Journal. Uh, uh, it's very respected journal, and it came out showing it was a double-blind, placebo-controlled study of two cohorts, 3 years old and 8 to 9 year olds, and they clearly showed in the study that uh, food additives, preservatives, colorings, and flavorings contributed to ADHD. And so I think the pediatricians would go, yeah, right, yeah, right. Everybody talks about this stuff. Um, I don't think anybody really, you show them the article, if they weren't aware of it, you can't, how do you refute that? It was a very, very solid study. And I think that's what sometimes you need to pave the way. I think conventional medicine really always wants the double-blind, placebo-controlled studies, and I understand that. I'm very, I'm a scientist. I'm science-oriented, but the problem is when you're like myself on the front lines in the trenches, and you're treating people who are ill. There are certain things that you kind of know, and if the risk benefit is in favor of the benefit, way in favor of the benefit with a very low risk, sometimes you can't wait for those studies. If it's just about foods, who's going to pay to do all these studies sometimes? I mean, luckily that study was done. But so there are certain things we do on an empirical clinical basis. Obviously, we get testing to guide us, but for autistic kids, or a kid with ADHD, or now some of the kids with mood disorders, if some of the testing is negative, I may talk about, hey, listen, these foods are inflammatory. Sugar is inflammatory. Gluten and dairy can be inflammatory in many kids. So if their brain is inflamed, and that's what I come to with after thorough history and physical and maybe some initial labs, I say it may be worth a try. It may not be easy, but we usually give a trial of off dairy for 3 weeks and gluten for at least 3 months. So it takes a while, but that's just on an empiric basis. The other thing I'm guided, obviously, if I see food allergies, then obviously I take them off the allergic foods.
You mentioned how corn is found in so many processed foods. How do you go about helping these kids when you tell them, certain things that they've been eating their whole life, like gluten and dairy, corn again? How do you go about getting them to stick to this? Or do you find that's not a
No,
problem? A conversation
no,
is
oh, no,
enough?
no. No. It's a problem. Let's be real. It's no doubt. I mean, the patient I just had this morning, let's say, right? So it's a teenager and having uh, a number of issues, including recurrent hives, right? And some anxiety and certain, psychological symptoms, right? Um, with a history of brain inflammation in the past related to an infection. We call it infection-triggered autoimmune brain inflammation, something I call ITABI in the book, but has also been referred to PANDAS if it's strep. But what's the diet? The diet is total sugar, right? Total sweets right now. And I think there's a yeast imbalance. I call it a fungal dysbiosis. In other words, an imbalance in the intestinal flora, and I think too much yeast. Been on a lot of antibiotics, had a yeast vaginal infections. So what's the worst thing for that is sugar, and also the yeast-like things, for certain fermented things that she was eating as well. So um, in adults, of course, if it's alcohol, it turns out that vodka and tequila are not as bad, but beer is the worst, and then red wine is second. So when you think these things are going on, you have to tell them to stay away from it. And when I talk to them, dude, this is perfect. This morning, I, one of the things I've developed over the years, which has been really helpful for me, is to be straight with the teenagers and say, listen, I know you're going to hate me. You don't want to give this stuff up. I got it. However, how painful is it for you to play the sport that you love and break out in hives? So it's not directly food related, but foods. I'm not saying this was food related. This is heat, temperature changes, right? But even with temperature changes, it was probably initiated by a monovirus months before. And so you have to look at all the factors. That's what I do as a medical detective, basically. I look at the factors. So it turns out, I think mono was the thing that kicked it off. And now it's related to temperature changes. But how painful is it for you? Because she has inflammation of the thyroid. And when you have this thing called Hashimoto's thyroiditis, the literature has shown that in a certain percentage of people, gluten-free diet helps as well. So I talked to her. I said, listen, I know you don't want to do it. And I can't be over you. I always tell them, I can't be over with you with a stick. And neither can your parents all the time. You're a teenager. It's a matter of how much it bothers you. Do you want to take a Benadryl during halftime and be drowsy so you can't play your sport as well, which is I know is bothering you, or do you want to give it a shot that maybe you could really feel better and start getting rid of these really huge hives that are itchy and uncomfortable? And I tell them straight, and I say basically it's just a matter of how much it's bothering you and how much you're willing to do, because it's just no one, you're taking your antihistamines and all that stuff. It's not working. So I think she will. But you know what? That's something that you can't just tell them and then move on. You have to have these kind of conversations. You can make a joke about it. With some of the athletes in basketball, I might make some references to basketball because I love basketball. But whether it's soccer, or whatever, I can make some references. I know soccer. I coached. My kid was really young, and my kid was really excellent. One of my kids was a real excellent soccer player. So basically, I understand what it takes and how much running there is and how much sweating there is. So if you're really getting hives and you love it and you're an excellent athlete, it may be just enough to say, you know what, let me give it a shot. That's the implementation, though, Jesse, is figuring it out is one thing, which is hard as well. But the implementation in teenagers is very challenging, and that's where you use the art of medicine, not the science.
And you mentioned there how you can, explain why this is important, but you can't really hold their hand and watch over what they're eating, and parents can as well. But would you have any specific recommendations for parents who are trying to implement, say they're trying to cut out gluten and dairy and they're trying to help their child with who's suffering right now with the mental health challenge? Would you say the best thing they can do is to maybe try and embrace that dietary change themselves?
You really ask really great questions. I think yes, because if you keep gluten and dairy out of the house, at least you can ensure that they're not going to get it in the home. Now, if they get it at their friend's house or at school, not much you can do about it. But and the only thing you can do is impress on them that when you do these eliminations, you have to be strict. Because if you have a little bit of gluten, that little bit of gluten can throw it all off, and it may not happen right away. It may be a day later, and it may last for a while. So you have to impress upon them that this is one of those things. I'm a moderate. I really am a moderate. But when it comes to figuring these things out, you need to be very strict at the beginning, or else you'll blow the whole diet. If you're gluten free for 6 days and then you have some gluten, and one of the studies on gluten free diets that said it didn't work. That's what they were giving these challenges every week. Well, you can't give a challenge every week because the diet won't be effective, because that will blow the whole thing. And so you have to understand that. So there is a time to be really strict, and there is a time to be moderate, and there's a time to relate to your kids and let them know, hey, listen, I mean, you feel terrible. We want to help you so much. I tell the kids, listen, you don't, do you, if you're not going to do anything, be straight with me and your parents and talk, because you don't want to waste my time and your parents' time and money if you're not going to do anything. Because I don't have, and listen, I gave a couple of medicines here that I think are going to help as well. But, sometimes the diet is really crucial, especially with hives. Well, this wasn't mainly food-based hives, no way. It's just that the whole concept of what I'm talked about this morning, and I would talk about now, is that when you're looking at these chronic problems, it's frequently not just one thing. It's not like a strep bacteria causes a strep throat. And I write about this in very early on in the book about the immune kettle. and look at it various layers. And as you pile on the layers, you get closer to the top, and that's when you get your symptoms. The lower you lie in the kettle, by taking care of numerous areas, such as, you can't do anything about the genetics, that's at the base, but nutritional deficiencies or insufficiencies, allergies and sensitivities, hormonal imbalances, toxicants, infections, um, stress. Stress is usually a biggie, but you can usually tolerate stress better if you're lower down in the kettle with the other things. So I'm trying to always think of all these different imbalances, the microbiome, metabolic imbalances. And if I can correct them, sometimes I can help a condition that has, quote, no cure, but can help because you lower them down in the immune kettle so they can tolerate whatever is happening better. And they actually, if they don't get fully better, at least they can improve by doing that. And that's what I would say generally. And that's where diet fits in. If they can't do the diet, you're doing other things as well. Hopefully, they can take a couple of supplements, such as a probiotic or vitamin D, and maybe an antimicrobial if they have an infection. Um, but I think the key is to recognize that we have to deal with the various levels to help kids with these chronic disorders and adults as well. But we're talking about teens and adolescents and kids here.
I really like that immune kettle analogy. That makes a lot of sense. And you mentioned the infections that can lead to brain inflammation, the pandas, pans. You have what was the term you used there? You came up with your own term that
It's called the TABI, ITABI, infection triggered autoimmune brain inflammation.
this is a really important topic. I want to take some time and really get into this. You mentioned your patient there that was suffering from mono, and the fact that this triggered, in this case, some brain inflammation and neurological symptoms and a mental health challenge. Let's take this from ground zero and really get into the details. Starting with, what kinds of infections are you seeing most commonly that are leading to the brain inflammation?
So, well, actually leading to it or maybe coming from it may even be what in other words, the brain inflammation. Well, the symptoms that may lead to, or the problems that may lead to brain inflammation may emanate from the gut.
Okay, the way I see it, let me just throw this out there before you get into it, is that somebody suffers from an infection like mono or strep, and then their body has an autoimmune reaction, and that causes inflammation in the brain,
Yes.
and that leads to the mental health challenges. Do I have that
Right.
right?
Yes. So what it is in ATABI or PANDAS, you get an infection, and strep was the most talked about one is PANDAS, but and that engenders some controversy because some doctors don't really believe in it. But then there are many other infections they can do with mycoplasma, viruses in this, and um, in this case, I thought it was the monovirus. So, and what happens is the immune system mounts a response to the infectious agent. Let me talk about pandas because that's the classic one, and that's from a strep. It's kind of like, I don't think anybody debates rheumatic fever, which is basically the immune system reacting to the strep. It's called a group A beta hemolytic strep. It's a very particular type of strep. And in rheumatic fever, there's a misdirected immune response, a very important word, misdirected immune response to a part of the heart that looks just like the strep. It's called an epitope, very, very tiny, a few, just a tiny, tiny piece that on the heart looks exactly like the strep. So when the immune system goes to get the strep, it sees it on the heart and causes rheumatic fever. Well, in these kids with a tabby or a pandas, listen, because I'm talking about pandas because of the strep, the immune system goes to attack the strep, and there's an epitope, this tiny little piece of the strep that looks exactly like a tiny little piece of the basal ganglia, which is down deep in your brain and is involved with emotions and movement. And that's why when the immune system attacks it, it causes inflammation and an autoimmune reaction. And thus you get disruption of the function of the basal ganglia and you get tics, like maybe blinking or just, yep. I mean, sometimes it's very profound. You can't, I mean, I see the kids in my office. Sometimes they're verbal tics. It can be very intense, and and then all these neuropsych symptoms, which classically is OCD, where kids are just they have these rituals. I have kids that it takes them 2 to 4 hours to come down from their bedroom to the kitchen for breakfast because of the rituals that have to do things 10 times, 20 times. Kid walks through the door 5 times before they can come in. One kid comes in, he carries a towel, he's got to put a towel on the way to my couch and then a towel on the couch to sit. Kids wash their hands multiple times. They perseverate asking, hey, mom, am I all right? Am I all right? Am I all right? Just nonstop. I'm talking about some of them are so severe. Anxiety, separation anxiety, they stop going to school. I have kids that come to see me, haven't been in school for 3 years. And they can get panic attacks. Some of them get hallucinations. Some get these intense mood dysregulation with rapid cycling mood swings and aggression. They can get suicidal thoughts, homicidal thoughts, intrusive thoughts that come in and tell them, do this, do that, got to hurt somebody. And they're going, I don't want, and they can't control it. And then there's some other physical symptoms. They lose their ability to write and draw. There's some striking examples I have where the writing totally goes to shot. Kids who were beautiful drawers and artists lose that total ability. They start urinating frequently. They wake up, they wet their beds at night. Kids that never did that. And it's not because they had you check them for an infection. They don't have a urinary infection. It's part of this whole brain inflammation that it's a whole part of the syndrome. So, and then they can also get the ADHD stuff, lose attention, concentration. They get hyper and fidgety, impulsive, and they lose cognitive ability. Not only the ability to write, they lose the ability to do math. We call it dyscalculia. And they start failing grades, or A students that start failing. So I'm talking about kids that I see that were A students, top level athletes, great kids, great part of the family, lots of friends, very popular, has it all going for them. And then and they get a strep infection or they get some other infection, which is not always a severe infection. It doesn't have to be. And then, days, a week or two, usually a bit later, the symptoms can come very quickly. Sometimes within days, sometimes overnight. Kid goes to bed one way, wakes up the next day, a totally different kid. And it is scary for parents. And the problem is it's misunderstood by a lot of physicians. And so the diagnosis gets delayed. And the earlier you can get inflammation, the easier it is to heal. The longer inflammation lasts in the brain, you start getting more degenerative changes. In other words, it's like neurodegeneration, in adults, Alzheimer's, Parkinson's, that's long standing. Well, in kids, the sooner you get it, the easier it is to reverse. We always have this thing in my field where if you have something for a certain period of time, it may take that long. A lot of times you can do it quicker than that, but you can't expect a long standing chronic complex problem to be reversed in a day. It just doesn't happen. It doesn't happen.
Well, let's stick on pandas here a little bit and use an example of a kid that, had a strep infection and all of a sudden, like you said, this can happen pretty quickly. They start suffering with all the different symptoms that you're talking about there, including OCD symptoms. What kind of testing are you going to do to determine if that strep infection is what is causing this?
Well, you can get a strep culture because sometimes the kids will have a positive culture and not even have a sore throat, right? Sometimes they have a sore throat. It's a little easier then. You can get these titers, these antibody levels. It's called ASO and anti-DNase B that you can get that can actually show you. It really shows you strep exposure. Okay, it doesn't. It's not in essence. It's not like a culture saying you have strep now. It shows you've been exposed. And when you deal with these things, same thing with mycoplasma or other kinds of infections, tick-borne. I don't want to forget Lyme, or I certainly don't want to forget Lyme or Bartonella, these tick-borne infections that also can trigger brain inflammation. And you'll never diagnose them if you don't check. That's one of the things I always say. Said it in that first book in '97. If you don't look, you won't see. And if you don't listen, you won't hear. So with the strep, we can check antibody titers. You can actually sometimes, even in some kids, I don't do this really a lot. Occasionally, if there's some anal symptoms, itching or this, that you may get a little swab of the anus because you can sometimes grow strep from there, but mostly it's from the throat. And a lot of times you won't see it in the throat because it already happened and the throat culture is not positive, but you get the evidence of very high titers to strep, which is consistent with the diagnosis. So you're trying to, and we can check anti-neuronal antibodies, is some of these specialized tests that can show autoimmunity to the brain, especially in the area of the basal ganglia. So you can show that. And with infections, sometimes you can show an acute type of infection. There's in the immune system, we respond very early on what's called an IgM reaction. And over the course of 4 to 6 weeks, that switches to an IgG, which is a longer lasting reaction. So if you see the IgM, usually it will be consistent with something more acute. But so you do your best to try to figure out what infectious agent it is, and then obviously you treat it appropriately. You choose your antimicrobial based on what it is, whether it's if it's like an Epstein-Barr, and I get in the history that wow, that the child took an antiviral for something and actually got better, and then of course only took it for a short time and then got worse again. I said, it's probably a good bet that the antiviral may be contributing to what this problem. And so I'll restart the antiviral and maybe an antifungal because I think there's yeast. And if I can prove there's a bacteria, I would, you have to treat with what you find, what you feel like is going on clinically, as well as what the labs confirm. That's what it's about.
So in the pandas example, to go over this again, just make sure we're all on the same page. The strep infection is causing an autoimmune reaction. So the body's attacking its own brain, specifically the basal ganglia in the brain. And somebody comes to see you and they're suffering with all these symptoms. You're able to isolate through testing and find out that there's, maybe in the past, maybe still active, a strep infection. What do you so you have to go back and eliminate that infection? Like, even if it's been, say this has been years and somebody's been suffering with different mental health symptoms since they were a kid and maybe they're even in their 20s now, is that infection still subclinical there and causing the autoimmune reaction for all those years?
Potentially be there, or you're just left with the autoimmunity. In chronic illness of infectious origin, at a certain point, we don't know where the infection ends and the autoimmunity takes off. There's probably some at a time when they're both present, and then potentially at a later time, maybe it's only the autoimmunity. Because you got to realize, you can get autoimmune responses to parts of the organism. You don't have to have a live bacteria to cause autoimmunity. You can still have an autoimmune response to a piece of it. So that's what makes this more complex. And like with Lyme, there's a whole controversy in medicine about Lyme disease. There are those doctors like me who believe that, yes, persistent or chronic Lyme can exist, and you have to treat it for a longer period of time to eradicate it. And then there's also another area of thought where basically it's that you treat Lyme for 2 to 4 weeks, you've killed it all, it's done, and everything that's left over, if there's still symptoms, or the symptoms come back after you stop the antibiotic, it's post-Lyme disease syndrome, post-treatment Lyme disease syndrome, PTLDS, I think, yes. Not PTSD, PTLDS. And I don't believe that. There's a lot of literature, more and more coming, showing that there can be persistent organisms. They're called persisters that can go dormant and then they can come out again. And this but this is unfortunately an area of controversy. And we literally have, it's very polarized, which I think is really sad for the patient because they may get these 2 points of view and they may have trouble reconciling them. And, but, I have no question that I believe it exists. I see it exist, and I've treated it and have gotten lots of people better. So same thing with pandas. We're there. So yes, you treat with antibiotics, but you don't only treat with a 10-day course you would use for a strep throat. You treat it for at least a month, sometimes months, and sometimes years, just like you would rheumatic fever. Rheumatic fever, these kids are treated till they're 18 or 21 sometimes. So there is precedent for these things. It's not like this is unheard of. And there are illnesses, infectious illnesses like HIV and tuberculosis that are treated for much longer times with antimicrobials, not just 10 days or what have you. So I think this is not like a new concept. It's just recognizing that, sometimes people need to be treated longer. And I see people that got a 10-day course because they had a strep infection, and maybe they even got a little better, but then they got worse again, and the doctor cultures them and says, "Oh, your culture is negative. You don't need any more." But they really do need more. It wasn't long enough. So, and I'm talking about antibiotics. And when I started my career in 1983, a lot of what I was taking care of was kids with recurrent ear infections who had been on lots of antibiotics. The parents brought them to me to try to get them off antibiotics. That's when I found food allergies. I found yeast in the gut, all these things. And so I helped a lot of them get off antibiotics. So that's how I started my career. Sort of be in a place now where I have to sometimes use extended antibiotics is totally something I don't love to do. You gotta understand that. But yet, when a physician like myself and colleagues in my field, you do what it takes as long as it's safe and the risk benefit ratio is way in favor of the benefit. You do what it takes to get people better. You just don't leave them and say, "Hey, you have this post-treatment syndrome and it's in your head," because, as I say in the book, a lot of these symptoms may be related to brain inflammation. It's not just psychological. The symptoms are psychological, but the cause is medical and biological.
So sticking on pandas a bit longer here, I want to make sure I have this correct.
I got you. No worries. I'm
With
with you.
with the strep infection, does the strep infection itself attack the basal ganglia plus autoimmune attack the
No,
basal ganglia?
no,
I kind of heard you say it can be maybe a piece of either one or a bit of both depending on the timeline, or is it
no. It's
all
strep.
autoimmune?
It's autoimmune and inflammation, but it's not the strep itself. No, it's the key is, and this is Sweeto. Dr. Sweeto used to be with the NIMH. Uh, uh, Used this term, and I love it. I think it's very accurate. It's a misdirected immune response. It's an immune response that should be directed to the strep is getting misdirected to the basal ganglia. It's not the strep. The strep is not. I was saying in tick-borne like Lyme and Bartonella, some of that is actually caused by the infection itself, and some is by the autoimmune inflammation related to the infection. But with strep, no, it's not the strep attacking the basal ganglia. No, it's the misdirected immune response.
And in your case, when you do the testing and find out that the strep is still there causing this autoimmune reaction, that's when you'll put the patient on antibiotics, potentially long term, to get to the bottom of that infection and totally eliminate it.
Yes, definitely. I think that's well said, but also recognizing we have to protect the the person, the teen or adolescent in this case, from the antibiotics. So we give probiotics and cobiotics. So we give, bacteria, good, diverse, healthy probiotics with Saccharomyces boulardii, which is a probiotic yeast that not a bad yeast, but a good yeast that prevents antibiotic-associated diarrhea because we don't want the complications. Sometimes I'll give nutraceuticals and herbs that protect the liver if one of the antibiotics is one that goes through the liver. So, we do a lot to try to protect the patient from antibiotics as well, because that's we want to have the safe use of antibiotics, not just. And we monitor labs every 4. We check a lab, liver, kidney, and blood counts every 4 weeks when they're on antibiotics, uh, because we want to make sure that there's nothing occurring that's a side effect of the antibiotic. So one has to be aware of it. You try to keep the microbiome intact as best as possible. And you don't just willy-nilly give antibiotics. You try to figure out exactly what they need and you treat it appropriately. Recognizing the impact of antibiotics. But I can tell you, and sometimes you can use herbal antimicrobials. We do that, and sometimes we will segue from pharmaceutical antibiotics to herbals. That we can do, and nutraceutical antibiotics. There are some of those, and they can be effective. But early on, I think really you need antibiotics unless a parent is totally opposed and we have no choice because they won't give it. Mostly we like to treat it as needed to eradicate the infection and then maybe keep it away with, changing over to maybe herbal and nutraceutical antimicrobials.
And you're talking here about, it's a serious thing when you're doing these long-term courses of antibiotics and you're monitoring the patient as you go through the course of treatment. But how often does it come up that you get these secondary issues from being on antibiotics for a long time?
Well, hopefully it doesn't come up as much with us because we really protect them. I mean, if you take the probiotics and prebiotics to promote diverse, healthy flora, and probiotics like Saccharomyces, and we adjust diets as well. We keep them off sugar and yeast, so they try to get them eating almost like paleo more. Not a lot of fruits, which have high fruit sugars and stuff, but you try. So you can try to be even stricter during this time to be preventive. So I think we have a pretty good success rate of keeping people in pretty good shape. Do you get diarrhea every now and then? Yes. And certain antibiotics will do it more than others. And sometimes a change and giving an antifungal will help, or a medicine for anaerobes that may grow because of the antibiotic. The worst side effect in the gut is C. diff. It's a Clostridial difficile infection in the gut from an antibiotic. That's very significant. You have to stop the antibiotics and treat it appropriately and make sure you get rid of it because it can recur. That's very, very infrequent in my experience. But that's one of the things we always worry about. And that's why if you're seeing diarrhea, you have to respect it. You have to hold the antibiotics. You have to check for C. diff. You may have to increase the things you're doing for the gut. But so you have to be aware of these things. But I have to say, we have a pretty good track record. And I know the physicians who understand all the other things you have to do rather than just give antibiotics would probably say the same. It's if you're somebody who's just giving antibiotics, you're going to see a lot more.
And how often are you working with somebody who, say, contracted, a strep infection maybe in their first 10 years of life, maybe in their teens, and then they're coming in to see you maybe in their 20s and 30s, and they've had this autoimmune onslaught going on for a long time. And then in that case, how reversible are the symptoms if it's been going on for years and years?
So I have people like that. I have one in mind who had very significant psychiatric, was labeled schizoaffective, which is a schizophrenia and affective disorder on heavy duty medicines for almost like bipolar and schizophrenia. And it turns out that I was able to diagnose this brain, infection triggered. I did my testing, I had my suspicions, and that's the kind of person you treat with antimicrobials. Um, but you also treated, and this was the most it's the most powerful thing I do. It's called IVIg. It's actually these intravenous immunoglobulins. They're extracted from thousands of units of blood. So it's a blood product. So you have to tell the patient they have to sign an informed consent. There's theoretically something can be passed from it, but the way it's processed now, I've been told nothing could survive. But and it can cause anaphylaxis. It's in the literature. I've never seen it, and I've done a lot of these treatments. So um, and they can. It's a very large molecule, so it's a stress on the kidneys. So you have to make sure you hydrate very well. So there are things you could have to do, and then a day or two after it, you can kids and adults can get bad headaches and vomiting and muscle aches like the flu, kind of like you can get that. And um, generally, you can control it, and we have ways to do it now. We give extra fluids. We give even more fluids the day after the IVIg. But you have to be aware of these. There are side effects, and everybody's got to be told the side effects. They sign informed consent. But the IVIg is a way of quelling or quieting that autoimmunity in the brain. And this is not a low dose IVIg, which is given for immune deficiencies and recurrent infections. This is a higher dose, 2-day treatment that's given. So you give half of it one day and half of it the next. And it's pretty much for us an 8-hour treatment because we're giving fluids before, during, and after to protect the kidneys, to keep somebody hydrated, try to minimize the side effects. And then even if you can, the next day we give them IV fluids with magnesium and things to try to prevent the headache. And we give them medicines to try to prevent nausea and the headache. So we have a system that we've worked out quite well over the years. But that, like for this patient I'm thinking about, was an adult, a younger adult, but an adult. Um, it could make profound changes. Problem is, it's got side effects. It's very expensive, and insurance doesn't always cover it. So some people can't get it, even though it may help them. But sometimes it is covered, and some people can't afford it, and um, it can be, it's one of the things that can really make a difference when it's been there longer term. So that's what I mean. You try to layer the treatments. You try to figure out what level you have to go to. Obviously, you don't jump to IVIg because it's going to have side effects and it's expensive, et cetera, et cetera. But when something is severe, when I have a kid who's homicidal or suicidal or totally psychotic, and they're on all kinds of medications. See, those when there's brain inflammation and it's causing neuropsych symptoms, those are the patients that don't respond great to meds, psych meds. That's a clue that maybe there is something behind it. And there are those patients, and if your listeners, any of them is in their family, you realize, wow, because a person that responds extremely well, maybe that's all you need. Obviously it's better to get to the source, but at least but there are numbers of people who actually respond adversely to SSRIs like Prozac or Zoloft or Lexapro. There are some who just don't respond, and those are the one that makes you think of, aha, is there something medical biological going on? Could this be tick-borne? Could this be autoimmunity, etc.? Is that kind of clear about that? Because that's a very important point.
No, that's great. And when it comes to the people that are responding in this way and having the autoimmunity versus somebody that might just clear the strep infection and then move on and not experience symptoms, right away or later on in life, does that come back to the immune kettle you talked about earlier? Is it, in your opinion, or with what you've seen in the science, is it these people that have compounding stressors in their life that are going to react and develop pandas in this case when we're talking about strep?
Well, it's also genetics. I think a genetic predisposition here is a big piece. It's the way your immune system responds. It's the kind of genetics that has that little epitope be the same as the epitope on strep. It's how your immune system is skewed, and that comes from exactly the microbiome and toxicants and stress. Because you've got to remember, Jesse, stress causes systemic inflammation, and so it contributes. It's a big contributor, but sometimes it seems like the only contributor is attributed to stress, but it's only stress topping off all the other layers. But in the case you're talking about, you can't underestimate the genetic predisposition, and that's something we can't really affect. We can affect all the other layers. You can affect epigenetics, things that affect genetic expression. And sometimes I'll tell people what I do in our field. I do something called nutritional modulation of genetic expression. You can actually modulate genetic expression. You can't change the genes, but you may be able to modulate the expression of the genes. So I would say, and what you're saying is there's definitely a genetic predisposition at the base of that kettle that's setting them up.
And when it comes to modulating how the genes are expressed, are you doing some kind of genetic testing to see, where that person's specific genes are to start, or how does that look?
Well, we don't test every gene, but frequently what we test, because it's important in metabolism and detoxification, is the MTHFR. It's a big word, methylene tetrahydrofolate reductase. I like it, I wanted to say that fast. We rather call it MTHFR. A lot of people have heard that actually. It's the gene that's responsible for the metabolism of folate or folic acid to the active methyl tetrahydrofolate, what we simplify calling methylfolate, which is the one that gets into the brain, is active in the brain. And if you have a mutation in that gene, you are much less efficient at making the active methylfolate. One one mutation maybe 30% less. So two mutations maybe 70% less. That's huge. So we have patients that have two mutations. So how we deal with that is we give methylfolate and methyl B12 to promote methylation. We bypass the block of an inefficient enzyme and give them the, the product, which would be methylfolate. So there are ways to modulate genetic expression. If a gene is coding for an enzyme that's less efficient, and that enzyme uses vitamin B6 as a cofactor, we can give vitamin B6 and try to help that enzyme work better, even though it's less efficient because of the genetics. So we can modulate genetic expression in those ways, and it's nutritional, really. Mostly it's either minerals or vitamins. And numbers of times they're B vitamins and magnesium and zinc and various things. But it's a very, very important part of what I do. But I don't test every gene on every patient. But I do test the MTHFR gene a lot, certainly in autism and ADHD and mood disorders. Check it a lot because, an interesting thing is in depression, one of the adjuncts to SSRIs like the Zoloft, the Lexapros, are it's called the pharmaceutical is called Deplin. They have it as a nutraceutical without all the additives and stuff. It's a 15 milligrams methylfolate, a high dose methylfolate. But the whole point being is that can help depression, and the SSRIs work even better. And why? And sometimes it's given without even testing. We always test. And if you see what's called the homozygous polymorphism or two of those mutations, then they need it even more. And so it's a clue. And again, remember, I'm always trying to put the clues together as what does this patient need? And it's usually not only one drug. That's the problem. It usually is a combination of medications, nutraceuticals, dietary modifications, maybe even detoxification, and then, of course, medications as well, but not only medications.
I hear you. And Lyme disease has come up a couple times. So I
Yeah,
want to take
yeah.
some time and really delve into this because it's not something I've gone too deep into on the show to this point, and I know you're an expert in this area. So to start off, how many patients are you seeing that are affected by this?
That in my practice, thousands. We've had thousands. You got to realize I'm in an endemic area, Dutchess County, which is 2 hours north of New York City along the Hudson. Beautiful. And, I live in Woodstock, which is in the mountains, but my office is across the river in Dutchess County. It's beautiful, but also deadly because there's, in my yard, there's tons of deer all the time. I mean, it's like a joke now. They don't even run anymore. I'm literally, you walk out to a deer, he looks at you and he flips you the finger because it's like, it used to not be that way years ago. They used to run, but it's like, so, and the ticks it's endemic, and the ticks are infected, very high percentage. It differs in different areas, but not only with Lyme, but also with these what we call these co-infections, Bartonella, Ehrlichia, Anaplasma, Babesia, and even many others that are more esoteric in the sense they're not thought of, but may require different antimicrobials to treat them, or combinations of antimicrobials. So Lyme is, so my first patient with Lyme goes back to 1985. I can remember it distinctly, 1985. And I just about missed it because what did I know? This is my first patient with Lyme. I'd been in practice 2 years. Guy comes in with a swollen red toe. And I thought it was just an allergic reaction, a swollen red toe, or maybe, a sting or something. I gave him Benadryl, no response. And it was persisting. And and this is me. I like to get answers. I go, what's going on? Why is this not responding? I mean, if it was certainly an insect sting or allergic reaction, it should respond. And then I got some more history, which is what I do. And it turns out he had just been vacationing in Block Island, which is endemic for tick-borne disease. Very endemic, means there's very high incidence of it there. So I look up Block Island and I see this thing about Lyme disease. I go, wow, Lyme disease, that's interesting. And it talks about swollen joints and things and blah, blah, blah. And I said, wow, maybe he's got Lyme disease. I didn't know. I can't remember the exact testing. It was 85. I do remember I gave him doxycycline. That time only 21 days. I wouldn't do only 21 days now. I would do longer. But, that was 85. And I remember patient got better. And that was my first case, which I would have missed had it not, persisted in spite of usual treatments. And, and luck, I have that intellectual curiosity. I like to get to answers. And that began my career in Lyme disease. And then, of course, see, the thing is, if you're not aware of things, you don't see them. That's the truth. And so once you have the awareness, you start seeing more and more. And of course, where I was seeing even more acute stuff because there's a lot of tick bites and the rashes. That's the easier stuff. That's the easier stuff to quote cure. It's the long longer lasting chronic stuff, that's very difficult. But then once you heal a lot of patients in the communities of these people, the word gets around. And we didn't ever had to advertise it, just the word got around, and that more and more people come. So over the years, thousands of patients I've taken care of, and of course I take care of so many kids. I take care of tons of kids with it. Not as many people take care of kids with Lyme. I mean, the pediatricians treat acute Lyme more, but in terms of these chronic complex cases, so and I've talked about it in the books I've written and things, and so people have you know come, and yet interesting enough, when patients have come uh, overseas for treatment of the autistic kids, by being here, some of the other family members have become infected with Lyme. And it was important to pick it up, to recognize what was going on, because if they went home without getting picked up, um, it could be missed because somebody in Thailand or might not be aware of Lyme disease. So, and if you miss these things, it's a real tragedy for the patient. I always say that the opportunity here, and that's why I wrote the book, is if we can pick up brain inflammation and what may be underlying and contributing to the brain inflammation that is contributing to these psychological symptoms, then we have the ability to change the trajectory of a kid's life, in this case, a teen and adolescent. I mean, you may be able to get them off psychotropic meds, you may be able to get them out of therapy, you may be able to prevent institutionalization, where if you never pick that up, it may be a totally different and unfortunate trajectory. And that's why it's so important to be aware of this stuff and do the best you can. Listen, you can't always get everything, but hopefully we can help lots of kids with this kind of awareness.
So, other than somebody coming to see you that lives in an endemic area for ticks, what other clues are you looking for when you're doing that history with somebody? What other symptoms are you seeing when somebody is suffering from Lyme disease?
So, okay, so just like I said, there's so much overlap between these various disorders.
Right, which I get, but what would be some of the big red flags to you to say, I maybe want to do some further testing and see if Lyme is
Well, firstly, okay, so let me just say that one of the things that can maybe help your viewers is uh, at the end of every chapter in the book, like the one on tick-borne disease like Lyme and Bartonella, I do talk about the clues and questions that you can look for and ask your doctor, etc. And some of the clues for Lyme disease are very, very important. Does the patient live in an endemic area? In other words, where there's a lot of tick-borne disease, or there are a lot of deers, and things like that. Um, do they travel to areas like that? In other words, so Dutchess County, Long Island, the Hamptons, Massachusetts, along the shore, Massachusetts, Connecticut, where it was first discovered, all these, the Northeast is endemic, but also the Midwest, Northern California, all endemic for Lyme disease. Okay, so very, very important that you get exposure history. There's the child or teen or adolescent outdoors a lot? Do they hike in the woods? They go camping with the family? Do they play a lot of outdoor sports? Soccer is notorious, kicking a ball in the woods, going to get the ball, right? These are all things that make you think, aha, it's more likely. Has there been a tick bite or some kind of bite they didn't even know of, and a rash that they didn't pay much attention to? The problem with that is at least 50% of patients never have the tick bite or know about it, or never have the rash or know about it. So, um, and then the symptoms could vary um, so much. So I mean, any disorder that involves, um, I call it a multi-symptom, multi-system disorder. That's how I define these things. So Lyme is notorious, starts in the skin in a lot of cases, but not all. Then it spreads through the blood. It's called, and it can get to the heart and cause palpitations, uh, rapid heartbeat, shortness of breath, heart blocks, even various kinds of heart block. Gets to the joints and can cause swollen joints arthritis. Um, and it gets to the brain. It can cause all kinds of cognitive dysfunction, trouble finding words, decreased short-term memory, they call brain fog. But a lot of what you can see sometimes is you don't see the swollen joint, you just get the nonspecific. We call arthralgias, myalgias, joint aches, muscle aches. You don't get a lot of times very much fatigue. You don't always get a fever. Sometimes you can get a fever. Acutely, you'll get a fever, but sometimes you get these recurrent fevers going on, and that's a clue. Especially that may be a clue to babesia, which is a not a bacteria, but it's a co-infection with a little parasite that can cause a malaria-like illness. So in that case, you look at fevers, sweats, and chills. You look at air hunger. They can't feel like they're getting. They feel like they can't get enough breath in. Chest pain, even a cough sometimes. These are for the and Bartonella is a co-infection that can cause really bad neurological pain, neuropathies, severe headaches. Babesia can do headaches as well, but like an ice pick headache, um, and really, uh, rather than the bullseye rash, which can get to be like pretty large, it's a red circular rash, not always exactly circular. That gets expanding with a somewhat of a cleared center. In Bartonella, you can get what's called these violaceous or reddish purplish streaks. So sometimes I'll look at kids' backs and I'll see these really prominent horizontal or oblique streaks. And there's no weight gain or weight loss because they always say, oh, it's stretch marks. Stretch marks are usually flesh colored, and they're usually in the areas where you've gained fat and things. In the mid back, you shouldn't be getting those. That's a clue to Bartonella. Again, it's not 100%, but it's certainly consistent and you can use it as a clue. So they can, when people present, and then of course the other part of what I'm saying, I gave you all the physical symptoms. The other part is in kids, the only symptoms you might get from Lyme disease are neuropsychiatric, anxiety, depression, OCD, mood swings, panic attacks. I've seen insomnia. Nothing physical. Okay, no arthritis, no heart problems, just psychological. And those are the ones that I really think is important that people understand. You don't have to get all the other symptoms to be thinking of the possibility of Lyme in kids that may have live in the endemic area, travel, outdoor sports, hiking, have a pet that goes outside, and pet that may go in your bed and stuff. That was another clue. I don't want to miss that. So you just have to be thinking, not that every case is that. And of course, the blood work is not 100%. So there are times I test if it's positive, makes it easy. But if it's not positive, but I really strongly suspect it, I might treat on a clinical basis because it's that important. I've had many cases that had negative or equivocal blood work, but I suspected enough to treat them, and sure enough, they got better.
I want to talk deeper about the testing here and talk about what would a conventional doctor test for if they believe in Lyme and they're testing for it versus you mentioned the blood work there. Is it all blood or are there different tests? And what about co-infections? Is there different tests you're doing for those too or is it figuring out if they have Lyme first and then testing for co-infections?
No, 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 no. We test for Lyme and co-infections, and we do a full. We have a basic co-infection panel, which is what most doctors get, and we have a full, much more complete one that tests for tularensis and brucella, fever. Because the problem is there's various other co-infections other than the basic ones, and even when you test for babesia, most doctors will only check for Babesia microti, but there's Babesia duncani. Bartonella, we check for Bartonella henselae and Bartonella quintana, but there are also multiple other Bartonella species that we don't test for. So if they come up negative, it doesn't mean they don't have the other species, just that you're not getting the testing or it's not available commercially or routinely. So that's why I'm saying there are just times when I'm a clinician. I was trained at the University of Rochester by some really good, great clinicians. And I was taught how to do very open-ended, extensive interviews and excellent physical exams. And I feel like we get totally caught up in laboratory medicine, and that's all you treat, positive lab. And I don't really believe that. I believe I treat the patient. I always say I treat the patient, not the labs. The labs support my clinical impressions and can confirm them. But if I trust myself, I've been in practice 38 years. Hopefully, I've had enough experience that there are times when I feel like that. patient has to be treated. I tell them the risk benefits, I tell them the potential side effects, and that that we have to decide it together. But and that makes for much more of a physician-patient partnership. But the truth is, I have had many examples over the years where patients have improved because I've treated them clinically. Same thing for thyroid. Thyroid can underlie these. It's not Lyme disease, but can underlie a lot of these psych symptoms, especially depression. But and sometimes people are low normal thyroid levels, and they're not low, so most doctors wouldn't treat them. But yet they're at the bottom of quote normal. Well, you know what? That may not be enough for that patient, and a little thyroid hormone can go a long way sometimes in patients. And in Lyme, we know that there's something called Hashimoto's thyroiditis. It's an autoimmune thyroid disorder. And we frequently see it with Lyme disease, and it can get better sometimes with the appropriate treatments. But it may be that they have Hashimoto's and the thyroid's inflamed on an autoimmune basis, and maybe they need some thyroid. That may be even a clue that, hey, maybe there's Epstein-Barr, maybe there's Lyme going on that's actually contributing to that. And interestingly enough, what has been shown to be effective in that as well in a certain percentage of patients is a gluten-free diet with the Hashimoto's. So it all comes around full circle.
I like that. And say somebody's listening or watching right now, and I know you work with patients from around the world, so maybe they decide they want to go work with you, but say they want to work with somebody closer to home and they're listening and they think, maybe I do have Lyme disease. A lot of this is sounding really familiar. What would they look for in a clinician if they're going to go? Because, there's probably a lot of doctors that you mentioned this
Yes.
before that don't necessarily think this is actually a thing, or maybe they don't do the deep testing. What should somebody look for in a clinician that is gonna give them, the proper testing and treat this like a real thing?
Well, I would say you'd want to look to somebody who's more open-minded, who's going to work with you in more of a physician-patient partnership way. And there is an organization called ILADS, the International Lyme and Associated Disease Society, ILADS. And they have a list of, I don't know how many physicians. I'm sure it's 600 or 1,000 or maybe more. I don't have any, I'm really not sure. But most of them hopefully are Lyme literate. I can't speak for everyone. We call it Lyme literate. They're aware of Lyme. They're aware of persistent Lyme. And hopefully one of them can treat you, as well as potentially somebody who has some training in integrative medicine that's more aware of the microbiome and the importance and the ability to protect the microbiome. Those are some of the things. And there's that you can, as you go ask. It doesn't hurt to meet, to look around, meet with the physician, and then go spend a few bucks and meet with them and ask them questions. If they won't answer any of your questions, they may not be someone you want to work with. But it's okay. I've had patients interview me, and it's like they do it because they don't know me. They may read some things online, they may have read one of my books. I'm okay with that. And I'll say a lot of times I'll say at the beginning of the interview, well, because they've been seeing other doctors frequently. If they come from far and wide, they've probably been seeing somebody. So I said, what would you like me to do? And what part would you like me to play? I like to respect the other doctors. I don't want to step on toes. Do you want me to take over this? Do you want me just to give you a consultation? And sometimes they say, well, let's see what happens after the consultation. I said, that's totally fair. Let's go through this thing and see where you come to. And then they can, but I like to be very open and transparent. Not assume, because assumptions are really problematic in medicine. And I'll never forget a chief resident when I did that when I was a very young intern, and I assumed something, and the chief resident just gave it to me and said, "You know what assume means?" And I said, "No." What? He says, "Yeah, you make an ass out of you and me," and I'll never forget that. And it's good. Those are the lessons we learn in medicine. I was a young intern, and so I like to put it right out to my patients. Hey, what would you like from me? What can I do for you? Don't be embarrassed to tell me you're doing this with this one, that, but I want to know where we can be in reality. And I don't like when, I really don't like when there's like this competing stuff or this and that. It's like, it's in the best interest of the patient. What role would you like me to play? And how would you like to interact in the context of your other doctors as well? And then we take it from there and we try to work out what works best for them and their kids. I think that's. But if they somebody needs to find somebody locally. I mean, the one thing, just so you know, if people know, it used to be people used to have to travel to see me before COVID. Now with COVID, I do a lot. I've done a lot of telemedicine and video conferencing medicine for years and years. But even the first visits now, because of COVID, somebody can do we call doxy.me. It's our secure video conferencing, like a secure Zoom, so to speak, but it's doxy.me. And I can see somebody and actually figure them out and get testing and prescribe stuff. And I think this has been helpful in medicine. I don't think it's going to go away because I think it's been very helpful in medicine to reach people in rural communities and people who can't get care. But it allows people, if they need to see me, if I can help them and they're not getting what they want locally, they can schedule a doxy.me and, with either myself or my nurse practitioner, who's really fantastic, and and get help that way. But the other way is if they want to try to do it locally, for sure, they try to check on somebody who's Lyme literate, and I would say who's open-minded, willing to work in a good patient-physician relationship partnership, and who maybe is more interested in integrative medicine, so they have a sense of the microbiome, especially if it's for Lyme disease and you need antibiotics.
So earlier you gave the example of your first Lyme patient. I think it was all the way back in the 80s who had the swollen toe. And you mentioned giving them for that acute case, I think it was 21 days of
Boy, you have
antibiotics.
a good memory, Jesse. Good for you.
So I'm curious nowadays, if you're working with somebody and it is an acute case, what would you do for them? And then if you're working with somebody who's more chronic and they've been suffering with this, like, say 10, 15 years, how do you approach that case differently?
Well, the acute case, like I said, we just had one, today. My nurse practitioner had one today, and we would treat them. We never treat with less than 4 weeks, but generally, the patient was sick with fevers and headache and things. And it was acute Lyme. The test was positive IgM, which is the acute antibody titers. So their doctor was going to treat them with, I think it was 3 weeks of antibiotics, and we say, well, no, that's not really enough. I would prefer to treat you with 6 weeks because you were sick. Because see, Lyme disease bacteria is very slow growing, and you kill these bacteria when they're multiplying. And if they multiply very, very slowly, unlike a strep, which is multiplying like every 20 minutes, so you get at the strep and quite well. But Lyme is not quite the same way, and Lyme has an uncanny knack for burrowing, burrowing intracellularly, hiding in these biofilms, which protect them from the antibiotics, and actually morphing shape from a spirochete, a spiral-shaped organism, to a round body cyst, which is resistant to the traditional antibiotics, and you need some other kind of antimicrobials. So the bottom line is, for the acute case, I would say no less than 4, maybe 6 weeks, right? And with it, we'll give something like a Lyme transfer factor. We'll give probiotics, and Saccharomyces to prevent the antibiotic diarrhea, at the very least. May give some natural anti-inflammatories if they're really inflamed. And then for the chronic case, and this is Lyme, but it's also co-infections, it's going to be longer. It's going to be at least probably 3 months. For something that's been there 15 years, it's going to be longer. And you probably have to use combination antibiotics. One antibiotic is not going to be enough. It may be enough just for the early, like we said, but for acute case, for a chronic case, you have to think about the other possibilities, the biofilms, the antibiotics to get intracellular, and also the round body. Sometimes maybe a round body that you need to treat, and so that you may pulse it in there. And there's a whole thing of combination antibiotics and some pulsing regimens. So, and the key there, of course, is if you're going to use antibiotics for a little more longer term, that you protect them with probiotics and Saccharomyces, potentially hepatoprotective or liver protective herbs, and also you make sure you do safety labs on a regular basis. We do safety labs. I mean, especially if you're treating for longer term, every month we want to check liver, kidneys, and blood counts at the very least.
Earlier, you mentioned the patient coming to you and saying right off the bat they don't want to work with antibiotics as part of their treatment. So, if somebody has either acute or chronic Lyme, explain both. Have you or do you know of anybody that's been able to successfully treat that with, say, herbs and different supplements and not go the antibiotic route?
I do know of patients that have seemingly got better. I don't know if they're ever it's going to come back on them late. Lyme can sometimes sit there for months and even years and come back, just like syphilis. Syphilis would it'd go away and then come back years later. So, but I have a number of patients. I recall one that would not take antibiotics and did get better. And that's not my preference, and I would certainly have them sign tons of informed consent about what what I've recommended, because I think it's the right thing to do. But I'm not going to abandon a patient. I had another patient I can think of, not a kid, an adult, who was reactive to every single antibiotic, every one. So we went about with herbs, and there are homeopathic combination things we can use as well. But it turned out very interesting on this patient. Able to figure out it was the additives in all the antibiotics. I started to getting the pure antibiotic compounded, and she tolerated it, which was a great lesson. I'll never forget that. And she did get better with some of the herbs and homeopathics, but not fully. And it was only until we added the antibiotics and we sometimes give them together as well. What I would prefer is either give them together or start with the antibiotics and then, kind of transition to or move to herbs, nutraceuticals, and then eventually sometimes you end up with a homeopathic series in essence to try to clear it. You've tried to kill it, and now you want to clear the system, have the immune system help clear it and things. So you do some detoxification strategies and some maybe homeopathics. But like I say, I do think if I have Lyme disease or co-infection, I'm going to take an antibiotic. I mean, and a lot of times I can convince people because they know I don't really want to do that. I built my career dealing with the side effects of antibiotics. But, if this is what it takes, I treat patients. I don't treat dogma. I don't say, hey, no antibiotics ever, because, it's so many people have been helped. People who have not been diagnosed or treated and have been sick for a long period of time, and I've been able to help them. And the key is also to sometimes you do combination antibiotics that allow you to get them in different phases, and and maybe not use as high doses or whatever. So there's a lot of strategies. I can't get into all the different strategies, but the key is I like to see a patient be well, not getting better and better, that they're really at a good place for at least a month, if not two, before I'll stop the antibiotics. I like them to be better because I've seen so many times you stop it too soon and they relapse, and it's very frustrating. And and so that may lead one to consider various antibiotic strategies, combinations, pulsing regimens, whatever. But you have to understand different doctors will do it different ways, and there's not only one way. And there are many doctors on the other side who think that it's too much antibiotics and you should only treat no more than 4 weeks. So it's sad. There's more and more research coming out. Hopefully this will be quote settled sooner. We can come to some agreements because the patient gets caught in the middle sometimes. And for me, that saddens me that the patient gets caught in the middle.
Well, Dr. Bock, I know we got to get going here soon, but one area I want to tap into, I think it's really important before we part ways, is you're dealing with all these kids and teens and their mental health challenges, and I know it's wide ranging, all the different symptoms that and challenges that people are suffering from. But let's talk about the parents and the family. And I'm sure you see a lot of parents coming in and trying to help their kids and the stress that they go through as caregivers and people that, love these kids that are going through these traumatic times. So what can you say to parents out there who are going through this and maybe it's been a long road and they've been stressed out and suffering along their kids? How do they go about making sure they're, taking good care of themselves and propping themselves up through this process?
I am so glad you brought that up. And it's a great place to end because it's so important. I can't tell you how much time I spend. Frequently, I end up seeing the parents or one of them as well to help them out. But I tell them, they give everything to their kid and they forget about themselves. And I tell them very forthrightly, right out there, you cannot help your kid or provide for your kid if you get really sick or if you don't take care of yourself. you need to take care of yourself. I understand the desire to just take care of your kid, because I always say to parents as well as in my family, we say it into friends, you're only as good as your worst kid. I don't know if you have kids, but it's true. If your kid's not doing well, it gets you. And so, but you have to take care of yourself if you're going to take care of your children. So I encourage them to know that. So it's self care. It's not selfish. It's self care. Get therapy to make sure they are with loved ones. I mean, I always tell them that the two best nutrients for the immune system. And I'll ask you, what do you think? Vitamin C, vitamin D. People will say, right?
I would say love and support and community.
Good for you. I say
I
love and
think I
laughter.
read that in your book or something similar. So
Okay.
I had a little bit of a heads up, I
Yeah,
got
there
to
you go.
admit, but
Love and laughter. That's what I say. Love and laughter are a key. I love to laugh. I think it's very healing. There are studies to show that as well. But, so I want them to recognize it's important to, obviously focus on your kids' health, not forget about your other kids. And there's a chapter in the book about a kid who gets short shrift because an autistic kid gets all the attention of the parents, and we don't want to forget about the other kids and our spouse. We want to make sure we have that relation with our spouse, that doesn't get, the divorce rate is so high in terms of autism, and severe mood disorders can be that way as well. And so those are the kind of things. Love, make sure, you hug the ones you love, you're with the ones you love, you tell them how you feel, you hopefully can get laughter even though things are tough. And you're there for yourself and the other families in addition to the affected kid. That's how it ended.
well, I agree. This is a good place to end. I'm glad we went into that. And other than listeners and viewers getting a copy of your book, Brain Inflamed, Dr. Bock, how can they connect with you after the show?
So they can call. I mean, the phone number, it's called Bock Integrative Medicine. It's BOCK Integrative Medicine, 845-758-0001. They can go to the website, Bock Integrative. That's BOCKINTEGRATIVE.com, BockIntegrative.com. And or else they can go to the braininflamed.com website and they can get some useful information there. And if and if they had it, if they wanted some information about nutritionals and things, the site is called Bock Nutritionals with an S.com, and there's some good information there about some of those things I talked about. So those are ways, and I'd be happy to help them. And my nurse practitioner is fantastic if they need some help, and she's certainly available. And hey, listen, my staff always kids me about retiring. I say, why would I retire? I get the opportunity to help these sick kids and families, and hopefully I can contribute to their healing and improvement. And so it's a very gratifying feeling. So there you go.
Well, I can see your passion, feel your passion, and you're doing great work. So keep it up. I'm going to link everything up in the show notes so people can connect with you after the show if they decide to. And Dr. Bock, I just think this was such an important conversation, especially going into PANDAS so deep and Lyme, areas that we haven't really went so deep into in the past on the show, and it's going to help a lot of people. So thank you.
Thanks, Jesse. It was my pleasure.
Thank you.
Yeah.